So hello everyone. I appreciate your time and kind attendance to our third Spine Health Academy Symposium. It is a great pleasure to honor and welcome you all to this symposium. Wooridul Hospital has been practicing love to our patients with the value of minimally invasive spine surgery for the last 38 years. Spine Health Academy was built on this academic legacy of Wooridul Hospital and now hosting the third academic conference in Busan. In this year, we are celebrating and acknowledge our the publication of the textbook on minimally invasive thoracic spine surgery, and which has been performed steadily for decades under the value of successful treating difficult surgery through the discipline of training and achieving better results different from others. So it is such a privilege to publish this textbook. We are respected colleagues at Wooridul Spine Hospital. I sincerely appreciate our contributing authors to this textbook. It is a great thing that the only doctors at a single hospital group has written this textbook, and it is notable because it met the essential know-how of tens of years of advancing thoracic spine surgery and maintain a consistent treatment philosophy for minimally invasive surgery from the beginning to the end of the textbook. So as a president of our academy, I look forward to and welcoming you this conference. Thank you for your attending.
Next, Dr. Sangho will make encouragement remarks. Please give warm welcome for Dr. Sangho Lee.
Good evening, Dr. Daniel Rosenthal. Good evening. I am very honored to have distinguished guests from all over the world today. Minimally invasive spine surgery textbook launch academic symposium. I'd like to express my sincere appreciation to our doctors who participate in textbook publication and Professor Dr. Daniel Rosenthal and Professor Dr. Berabant and Professor Dr. Gibson, who wrote the admirable foreword for this textbook. And I wish all participants and guests enjoyable stay at this conference. I especially appreciate Dr. Jeon Sang-yeop, who organized this Congress very well, and the President of Congress, Jun Suk-baek, and the President of Gimpo Airport Hospital, Baek Eun-gi, and the President of Gangbuk Wooridul Hospital, Choi Won-chul. Thoracic spine disease is increasing nowadays by routine screening check of cervical thoracolumbar MRI. You need more active and positive, more prompt causal treatment to save your patient from intractable back pain and progressive weakness of legs due to thoracic spine disease. The traditional radical thoracic surgery for neurologic decompression requires extensive resection and vertebral and rebound, which leads to fusion surgery to prevent post-operative instability. That's why so many surgeons delayed the decompression surgery earlier until the patient have profound gait disturbance. However, causal treatment for thoracic decompression should be earlier at the stage of unbearable back pain and radiculopathy for prevention from walking difficulty and myelopathy. Because of delayed decompression in thoracic spine, in the world, eventually many patients causes myelopathy, which might be difficult to recover back to normal daily life again. For the safe and successful practice of endoscopic and microscopic decompression, instead of wide open surgery, the authors have put enormous effort and dedication to guide the doctors. Thank you very much again. It is our love and the passion for the patient to have hope and to save their life and health who suffered from the thoracic back problems. Thank you very much.
On the celebration of our thoracic textbook publications, we have invited the authors of these textbooks. For the session of thoracic disc herniation, we have 4 presenters. The first presentation will be made by Dr. Won-seok Jang.
I am Seoul Wooridul. 이거 옷 벗을까 이거? 네. 벗고. 예. I am Won-seok Jang from Seoul Wooridul Spine Hospital. Today, I will present the clinical presentation of thoracic spinal compression. The thoracic spine is a rigid structure between the mobile cervical and lumbar regions. The thoracic discs are relatively small and have well-defined nucleus pulposus and a denser annulus fibrosus. Its unique stability is the result of the surrounding thoracic rib cage. So, thoracic disc herniation occurs much less frequently than lumbar and cervical disc herniation. The diagnosis of thoracic disc herniation may be difficult due to the lack of the characteristic clinical presentation. Due to symptomatic obscurity, it is often overlooked in the patient suffering from the back pain. In 75% of the thoracic disc herniation patients, the factor level is below T8 and is mostly at T11 to T12. The majority of the cases are central and the rest are paracentral. The presentation of the thoracic disc herniation varies depending on the level involved. T1-2 disc herniation may mimic a cervical disc herniation and lead to intrinsic hand weakness and a Horner syndrome. Patients with thoracic compression can be divided into 4 groups, including axial pain, the second radicular thoracic pain, third group myelopathy group, and fourth the radicular lumbar pain by ossification of ligamentum flavum. First, the axial thoracic pain is usually localized to the middle to lower thoracic region. It's sometimes confused with the cardiac or pulmonary or abdominal pathology. Second, radicular thoracic pain is often described as an anterior chest band-like discomfort in the dermatomal distribution. The foraminal disc herniation in the thoracic spine can lead to the nerve root compression and severe chest or abdominal discomfort. Myelopathy is the third category of the thoracic disc lesion and it's the most serious symptom. the positive Babinski sign, a sustained clonus, wide-based gait, and spasticity are all the signs of myelopathy and indicate the marked thoracic cord compression. The presentation is a combination of ataxia, motor deficit in the lower limbs, and paresthesia or bowel and bladder symptom. The OLF at the lower thoracic spine cause various neurological symptoms, sometimes mimicking those caused by lumbar spinal disease, motor neuron disease, or peripheral neuropathy. These atypical symptoms make diagnosis challenging, which can therefore potentially lead to a misdiagnosis. Why the lower thoracic OLF caused the lumbar radicular pain or back pain, such as disc or stenosis. Thoracic OLF occurs most frequently in the lower thoracic segment, about T9 to T12 level. This lesion are the transition point between the thoracic and lumbar spine, where there is less anatomic protection from the rib cage. So, due to the difference between the spinal cord and the vertebra, T9 to T12 vertebra correspond to the L1 to L5 lumbar spinal cord. So, the T11 to T12 OLF could compress L4-5 level rootlet, and it caused the radicular lumbar pain. In addition to the typical thoracic back pain, this kind of atypical leg radiating pain is one of the thoracic OLF symptoms. To diagnose thoracic disc herniation or OLF, the clinician should listen carefully to this symptom and actively perform the physical exam and radiologic exam of the thoracic spine. Thank you for your attention.
Thank you. Next, Dr. Sang-Ha will present the PTED for foraminoplasty.
Thank you for Chairman. I'm Dr. Sang-Ha from Cheongdam Wooridul Spine Hospital. Now I will talk about the endoscopic transforaminal discectomy for thoracic disc herniations. Thoracic disc herniation is rare compared with the lumbar or cervical disc herniations. It accounts for 0.25 to 0.5% of all disc disease. It has mostly no symptoms, but progressive myelopathy or breathing difficulty, low limb motor weakness, radiculopathy not responding to the conservative therapy is the indication of decompression surgeries. Endoscopic discectomy for thoracic disc herniation can minimize the incidence of post-operative instability with the preservation of bony structures. And it can also performed under the local anesthesia, and it shows faster recovery compared with the open surgeries. And so indications are becoming increasingly widespread by increased need of patient and the progression of technical process. Indication of endoscopic discectomy for thoracic disc herniation is all soft thoracic disc herniation regardless of location from lateral to central herniation. Paramedian and foraminal disc herniation can be removed more easily than central herniation because we can directly access to the pathologic point. In the central disc herniation, it is safe to remove disc by accessing the subarticular zones after separating the dura and posterior longitudinal ligament and neural tissue. And then we can enter the disc space and we can safely remove the extruded disc. But currently, endoscopic discectomy is not practically applicable to patients with calcified disc or hard disc herniation. Thoracic disc herniation usually occurs in the low thoracic spine and uncommon in the upper thoracic spine. But endoscopic discectomy can be applied to all thoracic levels, but low thoracic spine, which has a wider facet width of facet joint and vertebral body size is larger than the upper thoracic spine, and so approach access can be made easier. And because thoracic vertebral body is a pear shape, and so it is possible to remove extruded disc from central to foraminal area. Our target of removal is central and subarticular and foraminal zone disc herniations. Unlike lumbar disc herniation, thoracic disc endoscopic discectomy for thoracic disc herniation requires a foraminoplastic approach. And so this kind of bone drills or bone removal or electrical endoscopic bore is an essential equipment of the procedure. For the successful clinical outcomes, preoperative planning is very important. In the axial images of MRI or CT scan, we may draw imaginary trajectory lines like this. Using this trajectory, we can measure the distance from midline to skin entry point, and we can measure the exact access angles, approaching angles. In first step is introduce needle insertions in the AP fluoroscopic images. Tip of introduced needle is heading to the disc space, and in lateral fluoroscopic images, the tip of needle approaches to the surface of superior articular process. And in oblique view, needle should be located between the rib pad and the pedicles. After touching the superior articular process, needle is sliding to the foraminal area. At this time, we can do the epidurography using radio contrast dye. And after epidurograms, we can identify the lateral margins of spinal cord. I think it's very important. After confirming the location of spinal cord, we can safely approach to the disc space. And also we can do the transforaminal block at this time that relieves the patient's pain during endoscopic procedure. And then needle is inserted to the disc space. after dye injections in lateral images, we can check the extent of herniation. And in AP view, tip of needle is beyond the lateral margin of the spinal cord. Lateral edge of superior articular process should be resected to enter the disc space, and along the guide wire, serial dilating cutting reamer can be used. And extent of bony resection can be controlled using these leveling techniques. This is operation videos. After inserting the working cannula into the disc space, first the internal degenerated disc is removed. After removal of degenerated disc, herniated disc, between herniated disc and the neural tissue is dissected. And then herniated disc can be safely removed using the endoscopic forceps. After removal of herniated disc, we can see the pulsation of the spinal cord and directly visualize the decompressed neural tissues. This is a PLL, and this is a spinal cord, and this is a perineural fat tissue. This is the illustrative cases. This patient presented with breathing difficulty and gait disturbance. Preoperative MRI shows the central thoracic disc herniations at T8, 9 levels, and patient received the endoscopic thoracic discectomy. After post-operative MRI shows the complete decompression of herniated disc. In summary, endoscopic foraminal discectomy with foraminoplasty under local anesthesia could be an effective treatment options for selected group of patients with thoracic disc herniations. Indication of endoscopic decompression is all soft thoracic disc herniations regardless of location, from lateral to central herniations. Thank you for your attention.
Thank you. Next, we have Dr. Shin-Young Lee from Daegu Wooridul Hospital, and he will make a presentation of migrated thoracic disc herniations treated by the PT.
Yes, I'm Dr. Shin-Young Lee. It is a great honor to attend the Wooridul Spine Health Academy. Thanks to Dr. Junseok Bae and all family in Wooridul Hospital, and special thanks to Chairman Dr. Sangho Lee. Today, I would like to talk about the posterolateral PTD for migration disc. There is part of that overlap with the contents of Dr. Shin mentioned earlier, so I will focus on the migrated thoracic disc. The history of spine endoscopy has introduced many articles and lectures here. So particularly in 1980 and 1990, Dr. Rosenthal and Hedong Jos inspired us extending the endoscopic technique limited in the spine, lumbar spine, to the thoracic spine. The difference from the lumbar vertebra is that the structure of thoracic vertebra is small and narrow, and mechanical stiffer and the blockadable rib. Foramen is oval shape and susceptible cord injury and the dural tear. Yeah, this is anatomy mentioned earlier. A training surgeon will bear in mind the anatomical part in the various book. This is a book of Wooridul Spine Hospital have published, and advisement for experienced senior doctors also will help to enhance our technique for the endoscopic surgery. Technique alone does not treat the patient. We have to consider which the main symptom is occurred and what the result consists in the examination, whether doctor's skill is ready and whether the patient agreed to doctor's procedure. There is many instruments. The notable instruments are here, the covered forceps and the high-speed drill. This operating room in the thoracic spine, the shadow of the lung can interfere with the operation. We should pay attention to the posture. This is the approach. Unlikely BATS PTD is proceeding as a unilateral procedure. This is a migrant system has been introduced in several papers. The roughly divided 2 or 3 types, low and high. When the disc is located on the low margin of the pedicle, we call it the very high-grade migration disc. The anatomical barrier, we need to know barrier to remove the migration disc. In the severe migration cases, we have to remove upper part of the inferior pedicle position, similar with the lumbar PLD. Skin entry point and insertion point of needle approximately 5 to 6 centimeter. Needle insertion and tie, and serial dilator and obturator. This is the position of working cannula. We can't advance the working cannula because of small size of the foramen and blockade of the lip. After foraminoplasty, we can advance this is the final position of working cannula. Unlikely foraminal discectomy, initial foramen is necessary because of the narrow extraforaminal tract and the disturbance of lip and the relative acute insertion angle. In case of highly or downward migration disc, the extensive foraminoplasty can be suitable and allowed to visualize the ventral epidural space. So there is some type of extensive foraminoplasty. Some cases remove the SAP, in some cases remove the superior endoplate of intervertebral body, and in some cases need the direct assessment of the working cannula through the transpedicular approach. Finally, we can remove the migrant disc using curved forceps gently. This is a case of the thoracic spine. Following case will show some case of endoscopy treatment of migration disc. Please understand that there are some cases of TL junction or upper lumbar due to the lag of the case of thoracic spine alone. This patient, 6-year-old female patient, presented with intercostal pain. The patient disc was migrated superiorly. The disc was carefully removed, covered the forceps. But the remnant disc here, and after drilling of inferior body, T10 level, after then we can remove another remnant disc. 74 years female patient came to hospital with paralysis with a leg. The carpal migrant disc over the downward was removed, preventing the dural tear. The 60-year-old man with the DM and hypertension came to hospital with a limping gait. In this case, since the disc was demonstrated, the central large extruded company over the migrated disc, first of all, foraminoplasty was performed more widely. The cannula was gradually moved around the center. The migrated disc was safely removed with curved forceps. This is case of 84 years elderly patient with presented severe sciatica. Looking at the MRI scan, you can see the disc that has been moved upward, containing strongly black annular tissue after drilling and after the insertion of laser. We can remove the thick annulus and migration disc. The following case will be skipped because of time limitation. Complications include the dural tear and epidural hematoma and the pneumothorax. Epidural hematoma and retropleural hematoma can be prevented using the silicone drain. Recurrence depends on the less decompression and the hidden fragment and some case of risk factor. This is summary. Endoscopic surgery for the ventral thoracic disc herniation is always changing, and the development of many instruments enable surgeon to perform the ideal outpatient surgery, PTD and safe and alternative. In some cases, extensive foraminoplasty allow the direct approach of the case of highly migraine and thoracic disc herniation. Thank you for your attention.
Thank you, Dr. Lee, for showing nice videos with your cases. Next, I wrote a chapter about the mini thoracotomy and microdiscectomy. My name is Sang-Soo-eun. For mini thoracotomy, you can either choose to do transpleural or retropleural approach. And this has advantage of direct visualization of central disc with minimum manipulation of cord. It is also less painful because it does not resect the ribs, and we can go up to the level of T4. Indications are soft and calcified disc on the central or paramedian side. When deciding the surgery site, surgeon should consider liver on the right and Adam-Kiewicz artery on the left. And skin incisions are 2 centimeters and 2 centimeters anterior and posterior to the vertebral body. Intercostal dissection are done through the superior part of the rib because the intercostal vessels and nerves are located at the inferior part of the rib. Single lung ventilation are used to retract the lungs. And posterior part of the disc are covered by the rib pad, so sometimes it has to be resected. And the extent of the decompression has been drawn here. And partial vertebrectomy creates the working space so we can ventrally displace the disc materials and dissect the PLL off from the dura. So before the decompression, it is really important to have a true lateral image on the CM view, because if you don't have it, you might end up damaging the cord. So how you can achieve the true lateral image? The key point is the posterior arch of bilateral ribs. You should have an image that these structures come together on the same side. And then how deep you will go, you should measure before the surgery, and you should check during the surgery time. Parietal pleura could be torn, but chest tube is not always mandatory. You can just insert the chest drains. And if the visceral or the lung parenchyma has been damaged, and if there's air leaks, definitely you should insert the chest tube with the bottles on. On the closure, intercostal muscles and the 2 ribs should be approximated with adequate tension at the maximal lung expansions to decrease the dead space. And most tricky area is the T12 L1 approach that we usually enter through the T10th rib, and the approach becomes transthoracic, subdiaphragmatic, retroperitoneal approach. And on the MRI, we should look at the cruise of diaphragm where it attaches. This is 7-year-old female patient with multi-level compression fractures, and then it becomes kyphotic with osteophytic formations that compress the cord. And I decompress the lesions through the mini thoracotomy. Thank you. Next, we have Dr. Bae showing the demo surgery for PETDs session. We have a Dr. Daniel Rosenthal from Germany who has joined through the webs. Dr. Rosenthal has participated in our textbook and also have written a really nice foreword. Dr. Daniel?
Yes.
You can start
Good
your
evening.
lecture. Thank you for being here.
First of all, Sangho Lee, thank you for the invitation. And I congratulate you and your team for the first real book dealing with minimal invasive surgery and thoracic pathology. That's something lacking since years in the scientific community. So all the best. And I hope this is one of the multiple books you will write in the future. I would just start with my presentation, showing you the topic that Sangho asked me to talk about, and that's revision surgery for thoracic disc herniation. Are you able to see my screen?
Yes, very nice.
Okay. I would like also to thank my co-workers, Ms. Rosa and Mr. Fernandez, together with Stefan Dützmann and Inge Preisel. They just gathered most of the data you're going to see and hear in the next minutes. For those who don't know me, I'm practicing now since almost 30 years in a small town called Bad Homburg. It's about 30 kilometers from Frankfurt, and it has nothing to do with the port in the north, that's Hamburg, and the place where Wolfgang Kaspar used to work, that is Homburg Saar, located down here. So the hospital where I'm practicing is a 500 beds hospital with almost all specialties except cardiac surgery. And I'm leading the spine department since 1998. When we talk about revision surgery, the first thing that we should know is when is revision surgery indicated? Because if you have a remnant of a disc herniation not causing any symptoms at all, then I would just don't go for surgery. However, if the disc is still causing the same symptoms as before surgery, or those symptoms are progredient, then it's a clear indication for surgery. Worsening after first surgery, I just put a question mark at the end because you never know how much is the patient worse. So if the first surgery ends up with a paraplegic patient, then there is no indication, in my opinion, for any revision at all. So the next discussion point is which side is the best to approach the pathology. And the discussion worldwide is always the same. It's anterior or posterior with all variations, anterolateral or posterolateral costotransversectomy, or whatever other techniques we have. So what do the surgeons that are advocating posterior approaches say? Basically, you should use a posterior approach because it's the most popular and you are used to it. And I feel much more comfortable. You have a short learning curve. Instrumentation, in case I need it, I can put it just without problems. You have the less chance of organ lesions, although you are not able to see any portion of the anterior spine. And you know that anterior approaches may have life-threatening complications. That's what you're going to read and to hear all over the literature worldwide. The real reason why the majority of surgeons are keen to use posterior approaches is that they have much less experience with anterior approaches, because all of us in the training, it doesn't matter if it's neurosurgery, orthopedics, or traumatology, all of us, the anterior approaches have been always put in a small niche, trying not to use them because the majority of the surgeons are not used to deal with anterior organs. That's more for general surgeons. That in fact in the States, you have general surgeons doing the approaches for spine pathology. So why should we use anterior approaches? Well, the first reason is that in our two publications, the first one 20 years ago, together with Curtis Dickman and John Regan, and the last one published just in December last year, we just said that over 97% of the revision surgeries we did were done because the patient had the approach with a posterior technique for an anterior located pathology. If you just compare the tables, I'm not going to get into details, just going to show you some important parts. The revision surgery in 1999 were 8% of 187 patients, totalizing 15. We just took, in our last publication, a time frame from 2013 to 2018, and we had 456 patients, and the number of revision surgery totalized 4.6. So we are not so far from what we published 20 years ago. The results are pretty similar. The three cases that worsened were worsening of intercostal pain for 6 weeks and worsening of hyposthesia that left on one patient on his left leg. So there were no paraplegic cases in any of the revised patients. Just as important, not only the thoracolumbar area is the most affected by thoracic disc herniation, but if you see carefully, half of the cases, 1999 and 2019, were located at the apex of the thoracic kyphosis. So just take into account T6 to T9 is as important as T9 down to L1. So why are anterior approaches better than posterior approaches in open surgery? Well, you have less tissue damage, you have control over the complete anterior spinal canal, you address the pathology directly, so you don't need any additional spinal cord mobilization or manipulation, and your learning curve, yes, you need a learning curve, but I would just like to ask Dr. Bay or Dr. Park, did you just born knowing how to do percutaneous thoracic disc hernia? No, you had a learning curve as any normal surgeon has. So anterior approaches is not magic, it's just a matter of learning how to do it. What is the other aspect important for anterior approaches and for the physiopathology? The blood supply of the spinal cord, as you can see here, is mainly brought by the anterior spinal artery, but it's most important the small collaterals coming from the anterior spinal artery. Why? Because you need about 35 millimeters of mercury to stop blood flow of the anterior spinal artery, but you only need 7 to 10 millimeters of mercury to stop blood flow of the collateral arteries. So small discs compressing the collaterals may cause exactly the same affections as big discs compressing anterior spinal cord. More important, if you look at the literature, 1976 angiographic study by Dockman and Grifton, they just say that if you perform a laminectomy with an anterior mass occupying lesion, there is almost no decompression of the spinal cord because the denticulate ligaments are still holding the spinal cord in place. So here you have two examples why you shouldn't approach anterior pathology by the back. And furthermore, the force that is impressed on the spinal cord can develop on different parts of the spine depending on the angle of incidence of the disc on the spine. So if you look at the computer simulated program, small disc herniations can cause paraplegia, while big calcified disc herniations may be asymptomatic. So what do you do with an anterior approach? You have straightforward, low-level complication, no infection. It's everything published out there. What do you need to know before performing surgery? You need a complete neurological status, not only because of the treatment, but also because of legal implications. Has the patient had any previous surgery, except the one that was attempting to remove the disc herniation, before you will approach it? And you need a surgical protocol of the other surgeons, because you need to know if you had a CSF leak previously, or if they ligated segmental arteries. And of course, full imaging setup with MRI and myelo-CT scan close up to surgery. We also use neurological status preoperative in some cases, and we improve rheology, giving the patients physiologic saline solution before surgery to reduce the thickening and to improve the rheology. And we start with a cortisone therapy of 500 milligrams methylprednisolone per day, 2 days pre-op. What do you expect to find intraoperatively? Some adhesions, probably the dura is protected by the PLL, so the adhesions are most of the time not a big deal. You remove the bone first and then advance carefully to the disc, and you may or not use navigation or neuromonitoring. In fact, I've never used neuromonitoring intraoperative for my surgery. Some examples, here you have a case with calcified disc hernia with a very, very small arthrectomy on one side, and you can see the disc is just saying hello from anterior. And here you have the solution with, in this case, thoracoscopic approach, removing the calcified disc. And I put the head of the rib always in between the vertebrae in order to achieve a bony fusion post-operatively. Another example in this case, again, hemilaminectomy, not even a costotransversectomy, and this was aiming only to decompress, not to remove the disc, because it's impossible to reach this mass with only that sort of opening. So again, posterior approach, posterior laminectomy does not achieve decompression of the spinal cord. Again, in this case, anterior approach from the left side, complete removal of the compression and bony fusion anteriorly. Another case, calcified disc, laminectomy, arthrectomy on the left side, the disc is still in place. Post-op anterior from the right side, bone, and the disc has been completely removed. I will show you this case. It's a mixed case of soft and calcified disc, again, with a hemilaminectomy, not attempting to remove that disc herniation. And in the video that you will see, we used what Dr. Shin showed with the mini thoracotomy. And we just add, in some cases, navigation, or as you can see here, the VTOM, that is a development I did with Karl Storz almost 10 years ago. The advantage is that with the exoscope, This is the post-operative MRI showing the complete removal of the disc herniation anterior. In conclusion, anterior approach is a non-life-threatening surgery. A revision scenario is not threatening at all. Good results can be achieved in the majority of the cases. Serious complications can be avoided, and you have to be careful in balancing surgery with the aim you have to remove the disc herniation. Thank you very much for your attention.
Thank you for your presentation. We have greetings from Dr. Roberto Fosave from Croatia. And okay, so for your presentation, Dr. Sangho Lee, please make some comment.
Dr. Daniel Rosenthal, it's great pleasure to hear your lecture about the revision surgery. But my question is, there are so many patients in Korea who developed the worsening of neurologic state after first posterior approach surgery. So as you know, many university professors in Korea, they tried to decompress thoracic OPLL by posterior laminectomy. So finally, the patient's neurologic status worsened. So 1 year's symptom duration after worsening is more than 1 year, so even 10 years.
Yeah.
So my question is, if your patient developed the worsening of neurologic states, developed paraparesis after first surgery, so can you try revise again anteriorly to remove the causal compression, calcified disc or OPLL or hard disk?
Yeah.
So
thank you for the question, Sangoli. Yes, we see it very often, and as I told you, in over 36 cases, if I add the publication and the cases, we had 99 with the last series we revised from my personal experience. We only had one case of worsening, not worsening. They left the disc inside even after a thoracotomy. But in the majority of the cases, the problem is you are not able to see the pathology if you come from the back unless you open the dura. There are some publications now popping up very often about intradural removal of disc herniations or calcified disc herniations. I'm not a fan of that approach, but I always say what works in the hand of a good surgeon should be used if he feels comfortable with it. However, back to your questions. Yes, you can revise patients with worsening post-operatively because having had a posterior approach. You can revise it anteriorly for any kind of fractures, OPLL, disc herniations, and in the majority of the cases, these patients will have some degree of improvement unless they have a marked myelopathic defect after the first surgery. It is amazing that, as I showed you in the pictures, these patients are all between 2015 and 2018, that even nowadays we are still having patients treated with laminectomy for anterior pathology. In my opinion, it's not up to date anymore.
So I have tried to revise the patient who developed worsening of neurologic symptom after first posterior decompression. So the aggravation have developed more than 1 year. So even 10 years already passed. So they, as soon as I found out that they move a little, just a little movement of a toe or little movement of a thigh, I tried to revise the anterior pathology. Amazingly, they responded. The spasticity reduced. Some patients, they could work again.
Yeah.
So your revised surgeries should be tried.
Yes. Yeah. No doubt about that. No doubt. The only exception is if you have a patient with a paraplegia, I would not revise because it doesn't bring the patient any improvement at all. If you still have some degree of movement or an incomplete paraparesia, then for sure I would go for revision.
Thank you very much. That's great answer.
Okay.
For the doctors joining through the webs, you can type on the chatting window, so I can read it. Does anyone have a question from the floor? Yeah. Thank you for your presentations. Dr. Bae. Sorry.
Hi, Daniel. Thank you for your grasping presentation. I really enjoyed your talk. I have one question that if you do a lot of revision surgery, I believe you're also suffering some case of dural leak during or after surgery. So can you share us your tips or tricks how you manage the dural leak intraoperatively or after surgery?
In this series of patients, either 1999 nor in the cases I've shown you the last 5 years, we didn't have a single dural leak. Probably if you have seen all the discs I've shown, and that's the typical aspect of the thoracic discs that are non-invading the dura. They are smooth on their surface. They are round and smooth. And that's an indirect sign that that disc is not popping into or perforating the dura. However, I have a lot of calcified disc herniations with a dural leak. And what we do is we just individualize the lesion, the opening of the dura. In some cases, we even enlarge that opening because what we do is we just bring the dura replacement intradurally. So we just close the defect using dura replacement. There are different names and different brands selling it nowadays. And then we just stick from outside spongy foam with fibrine in order to have a dual, let's say, closing of that defect. What is more important than what you do on the dura, for sure, the dural part is important, but I always put that rib that you've seen very close to the defect in order to have a counter pressure to the dura pulsation. and we'll leave lumbar drain for normally 5 to 10 days post-op. What we are aiming to is to have a adhesion between the parietal pleura and the thoracic wall and the spine, so that dural defect will be tamponade by the pleura itself.
Okay, thank you so much.
Thank you.
Good evening, everyone. I'm Dr. Unsuba from Daegu Wooridul Hospital. It's my pleasure to make a presentation at the third Spine Health Academy Symposium, especially focusing on thoracic surgery. Traditionally, thoracic OLF has been treated with open microscopic surgery or microendoscopic surgery using tubular retractor. But in recent years, there have been many trials to expand the indications of full endoscopic surgery, even for including cervical and thoracic pathologies. So today I'm going to talk about endoscopic surgery as an alternative treatment option for thoracic OLF. Let me start with a case illustration. The patients are placed prone on a Wilson frame on a radiolucent table under endotracheal general anesthesia. Considering that stable blood pressure is essential for endoscopic field bleeding control, and even small patient's motion can cause fatal injury to spinal cord during surgery, general anesthesia is recommended. The endoscope with a large diameter working channel allows the use of a large size punch and drill and root retractor with other instruments at the same time. Using fluoroscopy, the target disc space is marked. These days, I prefer to use portable X-ray with needle marking. 1 cm vertical skin incision is made over the disc space and 1 cm away from the midline. Under fluoroscopic guidance, a blunt dilator is introduced onto the interlaminar window and serial dilation is done. A working tube is placed with the beveled opening toward the medial side. Using endoscopic forceps and radiofrequency, the muscle and soft tissue is dissected from the lower surface of the upper lamina and medial facet and base of the spinous process. Rest of the surgery is same as open surgery. Interlaminar window is after dissection of the soft tissue. Interlaminar window is expanded using burrs and Carrington punch. An endoscopic high-speed drill is used to grind the lamina. Sometimes it can be used to thin the ossified ligament. After exposing upper and lower margin of ligament flavum, using high-speed drill, check the pedicle. 1 to 2 millimeters of facet joint lateral to the dural sac needs to be drilled. In this manner, operator can secure the safe working space for Carrington punch lateral to dural sac. An endoscopic forceps and Carrington punch are used to remove the ossified ligament flavum carefully. Finally, the dural sac is fully exposed. If the OLF mass has severe adhesion with the dura mater, surgeon can remove ligament flavum around the adhesion and leave the adhesion and free-floating thin OLF mass attached to it. Meticulous bleeding control was done using radiofrequency and hemostatic agent Flosil. Wound is usually 1 cm. The patient can get back to daily life sooner than traditional open surgery. Post-operative MRI and CT scan shows that OLF has been removed completely. Indication is important. The pathology of OLF could lead to dural ossification, which represents a technical challenge during endoscopic decompression, and those cases often exhibit more severe clinical manifestations and poor prognosis. Thus, patients with a lateral, extended, enlarged type OLF and no signs of tram track sign or coma sign on axial CT are reported to be good indications for endoscopic decompression. Multiple level of OLF, coexisting OPLL, or other spinal disorders are reported to be related to poor outcome. Thus, these lesions are not good indications of endoscopic treatment. Full endoscopic decompressive surgery can be an alternative treatment option with safety even for OLF. However, clinicians need to be cautious with proper indications in mind. The complete evaluation of preoperative CT and MRI will help to get a good surgical outcome for the thoracic OLFs. Thank you for your attention.
Thank you. It was a really amazing case. Next presenter is Dr. Hyung-Chang Lee, and he will talk about transaxillary approach for upper thoracic spine.
Hello, everyone. First of all, today I'm very happy. I'm very happy to hear the word anterior surgery is not life-threatening surgery. Thank you for Daniel Rosenthal. I'm very agree that word. Now I start. So before this, I see this case. This patient come to our hospital due to quadriplegia after lumbar surgery. After lumbar surgery at another hospital. So at that hospital, the patient hear the words, this disease is not inoperable. You cannot cure. But because the daughter of that patient is my friend, so I hear that words, no, it is curable. We can do surgery. So the patient came to our hospital and surgery like this. So it's very well done. He has OPLL at T2-3 level. We did that good surgery for this patient. So he's doing well. And the key concept is to access this level via third intercostal space. This is first, second, and third. And this is a patient position. So elbow is 9-degree extension and shoulder also 9-degree extension, and axilla is clear shaped. And level marking with under shear when we can draw line from the guidance. And first case is no. And second case, she admit our hospital because unable work. She has the thoracic OPLL T2-3 level, like this. And after surgery, we do good decompression at T2-3 level, and she able to walk and return to home. Thank you very much.
Thank you. Dr. Lee, you're making everything so easy. Next, we have Dr. Ji-Young Jo. She will speak about navigated oblique paraspinal approach for OPLL resections.
Thank you, Chairman. Today, I'd like to talk about navigated oblique paraspinal approach for OPLL dissection. After introduction of MR and 3D CT, detection of thoracic intracanal region is not difficult and faster. So relatively small size OPLLs has been found not so rarely. Some of them, not all of them, are definitely symptomatic. But their severity of symptom is not enough to bear a scale of big surgery. To overcome this mismatch, oblique paraspinal approach was used. OPA has been used in case of calcified thoracic disc herniation or herniation with bony spur. This approach is not applicable to all OPLLs. Just small central to paracentral thoracic OPLL and the single level or multi-level OPLL, not continuous time, are limitedly applicable. We heard about thoracic endoscopic discectomy via transforaminal approach in previous lecture. We also described the oblique paraspinal approach for thoracic disc herniation using tubular detector. This OPA is essentially similar to the endoscopic transforaminal approach and using bigger tubular detector about 18 to 20 millimeter. The initial delay is docked over the superior aspect of the base of a caudal transverse process and the lateral part of facet joint. Docking area of transverse process is drilled out, then a more oblique angle of tubular detector is achieved. This is to give better visualization of midline structure. This figure shows a tubular detector placed at the lateral part of facet joint between transverse processes. Because using small tubular detector, using navigation system is helpful. First, a high-speed drill is used to remove the lateral portion of the facet joint and the proximal TP to expose the superior and the inferior pedicles. The exposed field includes the lateral margin of the sacral sac and the external root. Then, the posterior vertebral body adjustment to the disc space can be drilled and removed. This created a large working space and through into which OPLL can be pushed. This is a case. A 62-year-old woman presented with a walking difficulty and paraesthesia. Preoperative MR and CT image revealed OPLL at 4.5. We performed OPLL removal via OPA. Complete removal of OPLL was seen in a postoperative image. Not this patient, OPA complication may occur as direct cord injury. Without the creation of this working space, cord retraction is inevitable and the spinal cord injury may occur. So the creation of working space is very important. This 57-year-old woman presented with mid-thoracic axial pain. She can diagnose at T10-11 OPLL with a spinal cord compression. We performed good OPLL removal with limited bone resection via OPA using OAM navigation system. This case is suitable OPA because a T5-6 small paracentral OPLL. Post-operative images show working cavity, ventral of OPLL mass. But cause of wide decompression, total facetectomy was seen. As a result, instability may occur, not this patient, which may be needed to be addressed by placement of posterior instrumentation. Preoperative images show a large left side T5-6 big type OPLL with severe cord compression. We performed OPLL decompression bilaterally. CSF leakage was noted and resolved. Despite of aggressive decompression, T5-6 is maintained without instability. Possible another OPA complications is for direct cord injury and CSF leakage. In some cases, to avoid complication, it is desirable to remove the save down and separate OPLL anteriorly instead of completely removal the OPLL, especially in patients with severe adhesion between the dura mater and the OPLL. Preoperative image shows T10-11 severe cord compression with OPLL. This is an intraoperative sham view during OPA. Tubular retractor was placed lateral passage joint between transverse process. Postoperative MR shows incomplete decompression. This patient noted severe adhesion, so ventral decompression with making large working space was done. Then OPLL mass was pushed anteriorly instead of completely removing. But after 3 months, cord decompression was noted. In conclusion, OPA40 OPLL is reaching direct decompression of OPLL and somewhat minimal.
We'll have a special invited lecture, which will be presented by Dr. Sangho Lee. The topic is about minimal invasive thoracic spine surgery.
Good evening, ladies and gentlemen. It's great pleasure to present minimally invasive thoracic spine surgery. Thoracic spine is naturally kyphotic, so that posterior decompression is less effective. Backward movement of a spinal cord is restricted, and thoracic spinal cord is relatively avascular. It's very vulnerable to ischemic injury. Especially ossified ligament, calcified disc adheres strongly to the ventral aspect of dural sac. So there are many difficulties in direct removal, and there are risks of spinal cord injury. So that we developed posterolateral thoracic endoscopy, transforaminal endoscopic thoracic discectomy with foraminoplasty is very simple, very safe, and very effective for treatment of thoracic soft disc herniation. You can see the pathway of canal is a yellow color. It's between facet joint and rib head. The indication of endoscopic surgical treatment for thoracic disc herniation is soft disc herniation accompanied with myelopathy, radiculopathy, or persistent back pain. The lesion could be treated at any site, central, centrolateral, or lateral disc herniation. And you can treat also some bone spur. Lateral bone spur could be removed as well to treat lobe decompression. Surgical procedure is done under conscious sedation. The patient is prone position with the knee flexion and hand up. You insert your needle from 5 to 6 centimeters lateral to the midline between facet and the rib head. When you arrive your needle to posterior vertebral body line, your needle tip should be at the mid-pedicular line on AP view. Then you do discography with the dye and the indigo carmine to differentiate the pathology and the normal spinal cord. The next step is posterolateral foraminoplasty. Foraminoplasty means you cut lateral facet with a trephine or with a endoscopic drill or side-firing laser. You can insert cannula and you can insert the endoscopic cannula. This is directly routed to the lesion and less morbidity, nearly no morbidity at all. It's appropriate for all disc levels. You can see the red color. The red color is between facet joint and the rib head. So you can approach by cutting of a lateral part of a facet. Then you can move. You can lever the cannula. So you can approach to the even center of disc area. You place your cannula by enlargement of foramen by serial direction and sequential reaming of the ventral and the lateral aspect of superior facet over guide wiring. And you place your beveled working cannula on the posterior disc space through the annular window at the mid-pedicular levels. Then you can see the lesion site. You can remove the herniated disc by microforceps. This is a 36-year-old male herniated disc at the T8 and 9. You do internal debarking first after facet cutting. You can see the very blue color of the herniated disc, which was dyed by indigo carmine. So you vaporize the annulus with side-firing laser, then you could remove the fragment of the thoracic disc. Then you can confirm, verify the dural pulsation is free. This is the end point of surgery. The post-operative MR show definite liver the MRI. And this patient had herniated disc at 2 and 3, a foraminal area. She had chest decomponents, posterior leg and the back pain and the depression for 20 years. Since high school girls, the cause was herniated disc 2 and 3, but nobody treated so far. But because this is too small surgery, so it took only 30 minutes after facetoplasty, after facetoplasty means foraminoplasty, we could have immediately find the herniated disc. After removal of herniated at the foramen, so we vaporized the annulus to clarify the margin, and you can see the decompression, the palpation of thecal sac. And this patient had a 55-year-old patient had herniated disc 2 and 3. So normally in United States, they need a big surgery. And the posterior decompression might be very dangerous. The anterior approach also need transaxillary thoracotomy. But this is very simple. It took only 30 minutes. You inserted cannulas, and you can see superior facet and the epidural space. So you can see posterior longitudinal ligament. The herniated disc very on AP view, very clearly removed. And she had herniated disc 7, 8, and 11, and 12. So after facetoplasty, I mean foraminoplasty, you can see immediately the herniated disc because it's a paramedian and central. So you need more vaporization of annulus. So after you remove the disc, you can see pulsating dural sac, pulsating spinal cord after a FET. Next. This patient had a thoracic herniation, T9 and 10, right side. After foraminoplasty, you can see very clearly the herniated disc, which was dyed by induced carmine. You can differentiate clearly the spinal cord and the herniated disc. The 12 o'clock, there is a spinal cord, and the 6 o'clock, there is a herniated disc. After you remove the blue color stained by the induced carmine, you can see the epidural space. The spinal cord is pulsating very well. Post-operative MRI show complete decompression of the spinal cord. So you can terminate your surgery because there is a free epidural space and the pulsation of a thicker sac. But this patient, a 61-year-old female, have gait disturbance and back pain, undurable, and there are very big central herniation at the level of T10 and 11. But the facet joint and the rib head is very thick. In that case, you can combine the microscope surgery and endoscope surgery. First, using microscope and tube, you do first the microscopic foraminoplasty. After, so this is inferior facet, half of inferior facet drilled out, and you can find the superior facet. You drilled out the superior facet. Then you can insert your working channel and endoscope. Through the endoscope, you can remove and you can vaporize the annulus and the herniated fragment. Also, you can extend the drilled out the facet again, so you can remove herniated central thoracic disc. So you can combine the microscopic foraminoplasty and the endoscopy. So this is a posterior longitudinal ligament. After opening of posterior longitudinal ligament, you can remove the central fragment and you can confirm the decompression of spinal cord, pulsating dural sac. So you can confirm the complete decompression. So the huge central disc completely removed and no morbidity, no complication at all. The advantage of hybrid surgery is a more flexible movement of working channel. You can clear surgical site of central located disc. It's easier to remove transligament type of disc. You can insert the working channel more safely. It's very good for running to transforaminal endoscopic thoracic discectomy, endoscopic anatomy. But so between January 2001 and December 2018, we did 92 patients with endoscopic discectomy, 48.9 years old, mean age, and the mean follow-up is 38.4 months. The most frequent labor is mid-thoracic area, T6, 7 to T8 and 9, 41 patients, followed by lower thoracic spine, 35 for T9, 10 and T11, 10, and also upper, and all the patients improved, significant improvement of pain, and ODI also improved. But how about migrated disc and hard disc? It's very difficult to treat the migrated disc and hard disc by endoscopic surgery. You need a bigger tube and a stronger instrument than endoscopic thoracic discectomy. George Young, she just gave lectures about the oblique spinal approach for thoracic disc herniation using tubular retractor and the robotic hold. This is very popular now in various countries and even Wooridul Hospital. So the approach target, the pathway is the same as where the endoscopy, but is a more steeper angle than endoscopic. But you can get the more horizontal angle, so you can see the pathology and the Tekkarsak like open anterior transthoracic surgery. You can see it very well. This oblique paraspinal approach is very precise. So you can do one level. This patient had herniation at T8 and 9, but there are bone spur and calcified. So that's why we choose the microscopic oblique paraspinal approach. Postoperative MR showed the complete decompression, and the skin is really minimized, is a minimal incision. And you can do 2 level at the same time, 7, 8 and 8, 9. So both the hard disc completely removed, and you can do 3 level. This patient had 6, 7, 8, 11, and 12. Even meningioma T6 and 7. So you can see the green color. So the calcified disc removed, and the green color right side removed, and all 3 level was treated. But there are some patients who have a 4 level hard discs. So you can do 4, 5, 5, 6, 6, and 7. Post-operative MRI show all the compression improved. But why anterior decompression for thoracic OPLL and the calcified discs? Because thoracic OPLL and the calcified disc compression the spinal cord, and the spinal cord distraction by kyphosis. So posterior approach, posterior surgery worsening the neurologic state for the patient. So only treatment with anterior decompression, it should be released from this distraction. The adequate approach is anterior to remove completely OPLL or calcified disc. So as just Dr. Young-Chang showed transaxillary approach for high thoracic disc, this patient is 2-3 big calcified disc. So, but high thoracic, but extrapleural approach without the rib restriction. You need a microscope, very good quality of microscope with a very long instrument, drills and the long. The point of surgical technique is you should decompress from pedicle to pedicle, not just the lesion site. From pedicle to pedicle, fully decompression is needed to prevent the worsening of a spinal cord injury. And you should, from upper to lower, completely, you should start at the upper level, normal side, to the lower side. Fully decompression is very needed. So you can plot it the OPLL by wide working space. You make posterior working space first with the bone resection. We call it partial corpectomy. You can see the fragment. The patient underwent transthoracic microscopic anterior decompression. So the total OPLL removed from T7 to 10 completely, but no bone fusion is needed because it's minimal invasive, minimal destruction of the vertebral body. So you don't need the bone fusion at all. This patient had a huge OPLL. The OPLL was completely removed without the bone fusion. Because of partial corpectomy linearly, this is a great wide working space. So you can push out the OPLL completely, and the normal spinal cord is pulsating. So from T3 to 7, so they can work again. They can manage normal life again. So from T6 and T7, T10. But in China, they still use some various hospital uses posterior decompression. In Korea also as well. 50% of thoracic OPLL worsened the neurologic state after surgery. But this anterior transthoracic decompression, no aggravation of neurologic state. So 6 and 7, so complete decompression of spinal cord. T10 and 11, the calcified disc removed, but the corpectomy is a partial and no rib resection. T12, L1. So you can see the decompression from pedicle to pedicle. This was published result of ossification OPLL in 2008, and George Young, she reported how to manage CSF leakage after anterior decompression of OPLL. And recently, Dr. Beijunsu reported transthoracic microsurgical anterior decompression without the bone fusion. So there were 35 patients, and the OPLL was most frequent OPLL was a big type OPLL. Mean thoracic OPLL patients was 58%. Complication was 15, but there's only one patient had a transient weakness. The normal simultaneous decompression through the single-stage mini thoracotomy for concurrent ossification of posterior longitudinal ligament and the ossification of a ligament problem at the same thoracic level. So I just explained to wooridul doctors, especially Junseok Bae and Sangho, just explain, you can remove OPLL and the OLF at the same time through mini thoracotomy. So I didn't explain it anymore, but they did a lot of surgery and they wrote the great article to the spine. So I was very impressed. What I did is just talk about, but they achieved. So the OPLL removers and the OLF removers at the same time with the same angles. For example, this patient had OPLL at 6.7 and the OLF and 6.7. So they tried the simultaneous decompression of OPLL and the OLF, one single transthoracic mini thoracotomy. So this is the view. So you can approach here and you can approach posterior, anterior and posterior at the same time. So the post-op MRI showed complete decompression both sides. And the post-op CT MRI showed complete decompression of a spinal cord. And 6 months later, still is a good state. 51-year-old female had OPLL and OLF at the level of T4 and 5. So look at the posterior post-operative CT. So post-op lesion and all the lesion is completely removed. 47-year-old male, OLF and OPLL, they removed at the same time by mini thoracotomy. 29-year-old had also calcified disc and the OLF, even young boy, 29-year-old male. But he developed paraparesis, so what he done is remove OPLL and the OLF at the same time. The patient can walk immediately. This patient, what I done in Shanghai hospital, Shanghai Wooridul hospital. So that's why I wrote 일석이조. It's Chinese letters. Get two birds with one stone. Thoracic disc herniation and OLF. This is not OPLL and OLF. And the thoracic disc herniation, and we treat the OLF at the same time. Minimally invasive thoracic spine surgery achieved early return to work with less morbidity to preserve normal structures. 어디 갔지? Yeah, to preserve normal structure. So the patient can do earlier normal daily and normal sport activity. That's a big difference. Thank you very much to publish the minimally invasive thoracic spine surgery. So I appreciate all the attenders and the seminar organizers, especially Professor Doctors Daniel Rosenthal. Thank you very much for your attending.
It was a great lecture. We would like to have Dr. Jeon Sang-yeop to have a closing remark.
It is great honor to invite excellent spine surgeons as a speaker into Busan city. And also thanks to all audience and staffs who prepared this meeting. Let's enjoy dinner and have a good time. Thank you very much.
Thanks everyone to join the third Spine Health Academy Symposium webinars. We hope to meet at the first meeting. Thank you.